Hi, my name's Neal Lakdawala. I'm a cardiologist at Brigham and Women's Hospital and Harvard Medical School. I look after patients who have genetic cardiomyopathies, especially genetic dilated, arrhythmogenic, and hypertrophic cardiomyopathy. Today, I'll be speaking about desmoplakin-related cardiomyopathy. And I have a number of questions that I'd like to run through to emphasize important points that I think every patient or family member of someone with DSP cardiomyopathy recognizes. So one of the first questions was, what are the unique considerations for people with cardiomyopathy caused by the DSP gene mutation? I would say there are three answers to this question. First and foremost, people with DSP cardiomyopathy should determine what their risk of life-threatening ventricular arrhythmias are. So DSP cardiomyopathy is associated with a higher risk of ventricular tachycardia, ventricular fibrillation, and these heart rhythm abnormalities can cause fainting and, more importantly, cardiac arrest and sudden death. So these are scary, terrible terms that we don't want our patients to encounter firsthand. And we've learned a lot over the last 5 years about how we can protect patients from life-threatening ventricular arrhythmias. So for that first important consideration, patients should know that there is now a risk score that can be utilized with their treating clinicians to understand what their individual risk of life-threatening arrhythmias are. And in order to have the data available to utilize that risk score, patients with DSP cardiomyopathy generally should have some version of a Holter monitor. This is a heart rhythm monitor worn for an extended period of time from 24 hours up to a couple of weeks. A cardiac MRI can be very useful both to characterize the size and the function of the left and the right ventricle. And then a careful family history. Not much beyond that, and usually an echocardiogram would be necessary to understand a person's individual risk and to ask the question, would it benefit you or your loved one to have a defibrillator implanted to protect against cardiac arrest? So that's the first and most important consideration for people with cardiomyopathy caused by the DSP gene mutation. I think another unique consideration that has become more apparent over the last few years are the occurrence of myocarditis or discrete events of cardiac injury amongst patients with cardiomyopathy caused by the DSP gene mutation. Myocarditis is recognized as an acute inflammation of the heart muscle, and people experiencing myocarditis often experience pain, and when they undergo cardiac testing are found to have injury based on blood and EKG test results that plays out over a period of a few days. The occurrence of myocarditis in people with DSP cardiomyopathy appears to be associated with future risk of heart rhythm abnormalities, and as I'll speak to later, may be a future target for medical therapy in the future. A third important consideration for people with DSP-related cardiomyopathy is the development of congestive heart failure, for which medicines have been developed and are available to prevent further progression or further weakening in the heart muscle. So people with DSP-related cardiomyopathy are often best suited seeing a cardiologist who has experience treating congestive heart failure or dilated cardiomyopathy. So those medicines are generously used to protect you, protect your loved ones from getting worse. And the last 3B or fourth consideration is just to recognize some of the other features that people with DSP cardiomyopathy may have. People often tell me, my patients often tell me about these, and you may be much more aware of this than your treating clinicians, but this includes very curly hair and coarse calluses or thickened calluses, especially on the soles of the feet. Those can often be associated features of people that people have who also have DSP-related cardiomyopathy. And importantly, the severity of the hair or the skin findings does not appear to be related to the severity of heart disease. So next, I'd like to transition to talking about disease progression and treatment options for people with DSP-related cardiomyopathy. So I'll return to the first point, which is that we need to understand an individual's risk for cardiac arrest or ventricular arrhythmias with DSP-related cardiomyopathy, because I would argue the most important treatment option is to consider implantation of a cardioverter defibrillator to protect you from life-threatening cardiac arrhythmias. For people who have cardiomyopathy with reduction in heart muscle pump function, you might recognize this as a reduced ejection fraction. Certain medicines are used to prevent heart muscle disease from worsening. Broadly speaking, there are 4 classes of drugs used. This includes beta blockers, one of an ACE inhibitor, an angiotensin receptor blocker, or a neprilysin inhibitor known as Entresto. The third class are roughly called mineralocorticoid receptor antagonists, which is a mouthful, but the drug names may be familiar. They include drugs like spironolactone or clarinone. And then the fourth class of drugs is actually a medicine initially developed for diabetes, but has been found to be useful for people who have cardiomyopathy and heart failure symptoms. And that class is called an SGLT2 inhibitor, a sodium glucose cotransport inhibitor. And that class of drugs has also been shown beneficial. So those 4 medicines are core treatment options along with a defibrillator. And depending on other manifestations or complications of disease, antiarrhythmic medications can be useful to prevent recurrent heart rhythm problems in conjunction with a defibrillator. And some patients benefit from a catheter ablation, where an electrophysiologist typically uses radiofrequency energy to cauterize locations in the heart that are particularly problematic in causing heart rhythm problems. Disease progression is somewhat unpredictable in that some patients can be stable for years, if not decades, with a certain severity of cardiomyopathy, and other people may progress. And better understanding who is at risk for disease progression is a major research priority. The last question to address is, what is the outlook for future therapies, including genetic cardiomyopathy therapies now and in the future? So beyond the medicines that I had mentioned, one area of interest is whether or not and how we should treat these episodes of myocarditis in patients with DSP-related cardiomyopathy. Myocarditis has been treated variably with medicines that diminish the immune system. These medicines are sometimes called immunosuppressant medications. They include medicines like prednisone and mycophenolate or methotrexate, as well as in some cases, people are just monitored and recover on their own. So one important research objective is to understand whether medicines should be used to treat myocarditis, especially immunosuppressive medications in people with DSP-related cardiomyopathy. Another therapy that we think will be useful for people with DSP cardiomyopathy in the future will be gene therapy. Gene therapy is being developed in other genetic cardiomyopathies, and there are ongoing clinical trials in people. There is not currently a gene therapy trial as of December 2024 for DSP-related heart disease, but I think we can look to the future and realistically be optimistic that therapies that target the underlying genetic cause will be developed and studied in people who have DSP-related cardiomyopathy. I want to thank you for your time and for being an audience today.
This video is part of a series of educational videos developed by the Genetic Cardiomyopathy Awareness Consortium and brought to you by the DCM Foundation. Our goal is to connect you with the leading experts in the field of cardiomyopathy to further your understanding of this disease and to provide resources to help you manage your care. Thanks for watching.